Let's walk through life cycle of plaque from the beginning. I know there's soft plaque, hard plaque.
Yeah.
I believe the soft plaque is the initial, and then eventually it becomes calcified and hard. But take it right from the beginning, and then we'll talk about best case scenario.
What you just said is a very commonly held belief, right? That we kind of start with soft plaque and over time it becomes calcified plaque. The reality is that we haven't quite proven that yet. And the reason brings up another important concept around heart disease. Understand that up until very recently, and I'm talking like the past 5 to 10 years, um, the only way that we would see plaque in the blood vessel, right, was either an autopsy was being done, right? Someone died, we opened up their blood vessels, we see what's going on in there. Or someone like myself, a surgeon, is going in there to operate on a blood vessel, right? And we open up the blood vessel and we see plaque. Now, neither of those things get repeated, over and over again throughout someone's life, right? The autopsy is obviously only a one-time thing, and even surgery like I do, right? It's rare that we're doing it, repeatedly on patients. Um, we didn't, up until very recently, have a good way of looking at plaque in people's arteries in living people and being able to do that, year after year after year, right, on a serial basis. We now do have very high fidelity scans of the heart that we can do that we can actually start to see the plaque. So a lot of our understanding around, soft plaque, calcified plaque, has to come from animal models, and we really don't have a perfect animal model of plaque. Other observations come from, okay, we sometimes end up doing autopsies on young people, and this is what we see in their blood vessels. And then we do autopsies on older people, and this is what we see in their blood vessels. And so, the thinking is, well, it's an evolution, but it might not be as clear as that. So, yes, you are correct. There are two types of plaque. Again, broadly speaking, there's what's called non-calcified or soft plaque, and there's what's called calcified plaque or hard plaque. And it does seem that the older that people get, the more likely they are to get calcified plaque. And when you look at young people, they generally don't have calcified plaque, but they may have some of this soft plaque. So there may be a time component to this. It may be that soft plaque does turn into calcified plaque over time. But again, we're only now starting to get very good data around this because now we do have these high fidelity scans that I can scan someone today and I can scan them a year later and I can see with great detail, this is where plaque was and it was soft plaque and now maybe it became calcified plaque, but that doesn't seem to be always consistent. Um, there may be other factors that cause calcified plaque to form sort of primarily, and non-calcified plaque to occur in other situations. And it may not be quite that one always turns into the other. We're starting to see patients in my practice, for instance, that they have calcified plaque, and then we scan them a year later, and the calcified plaque starts to disappear, which is a concept that wasn't really understood previously. And so we're starting to understand all of this plaque dynamics. But ultimately, there are two types of plaque. We can say that for sure. These plaques tend to behave a little bit differently, right? So the danger coming from this plaque are probably different. When we're dealing with soft plaque, there is a concern that soft plaque might be unstable. It might start to peel off the blood vessel wall, and this can set off a blood clotting response and lead to a heart attack, what we call plaque rupture. Calcified plaque, it starts to make that blood vessel more stiff, right? And it can't expand like it's supposed to. And it can start to sort of gradually choke off the blood vessel as that calcified plaque builds up. And the reality is that most of the time when you're looking at plaque in people's arteries, these two coexist. When you look at an area of plaque with these high fidelity scans, you're oftentimes seeing combinations of soft plaque with calcified plaque. So imaging has become a very important uh, tool that we can now use as we're trying to figure out heart disease for people, as we're trying to prevent and reverse heart disease for people. And this is really, I think, one of the things that over the next 10 years is going to vastly change how we approach heart disease. The fact that we can now dynamically see in living people what is happening with their arteries is really going to change our understanding of, you know, how things work when it comes to heart disease.
Somebody that wants to use one of these new tests, see where
Yeah.
they're at, what do you recommend?
I typically recommend starting with what's called a coronary artery calcium scan. This is a simpler version of the imaging. It's only looking at the calcified plaque in the heart, which is a limitation of it. But it is a easy to perform scan. Literally takes like 2 to 3 minutes. You don't have to put an IV in. You just lay down on the CAT scan machine and you go in and you come out, and we get to see, is there calcified plaque in the arteries of your heart? And this turns out to be a great screening test, right? I oftentimes, draw the analogy of the mammogram, right? And we're trying to see the disease, heart disease versus breast cancer on the mammogram at its early stages. And that's what, if we see calcified plaque, we know that you have already started this progress towards heart disease. And if we see a lot of calcified plaque, it tells us you might be far along in this process and we might need to be worried about you. So that's where I usually start. Coronary artery calcium scan, like I said, very easy to do, inexpensive. Most areas, $100 to $200 to get a coronary calcium scan. And I now advise all men, by the time you're 40, get your first one. Women, by the time you're 50, get your first scan. If you have reason to be concerned, if you are metabolically unhealthy, if you are insulin resistant, if you are diabetic, if you have a strong family history of heart disease, get the scan even earlier. Because the reality is that I have 30-year-olds ending up on my operating table these days. And that means that that disease started in their 20s, maybe in their teens. And so, screening earlier can be helpful in certain situations. And then those high fidelity scans that I was talking about, they're called CT angiograms. Now, these are a little bit more complicated. We need to put an IV in you. We need to give you dye through that IV. The radiation exposure is higher, and the expense, they cost more money to do, especially the kind of latest version of these that use AI technologies to analyze the pictures and analyze the plaque. These things are still somewhat expensive and they involve more radiation and they're more complex. So I reserve that as the second level. If your CAC score is concerning, we might want to get a CT angiogram. If you're having symptoms of heart disease, we might want to get a CT angiogram, but it's generally not the first test that I recommend to people.
How often are you scanning somebody, man or woman, middle aged, and finding no plaque?
The statistics are for a 40-year-old male, you're going to have about a 60 to 70% zero, 60 to 70% are going to have a zero score. When you're a 60-year-old male, you're going to have 30 to 40% with a zero score. So it kind of inverts there. Women tend to lag about a decade behind men when it comes to heart disease. So, 50-year-old women are going to tend to be more in that, 60 to 70% are still going to have a zero score. And by the time you get to about 70 years old as a woman, you're probably down into the 30-ish percent zero score.
Since you made it to the end of this clip, I know you're going to love the full episode. Click here to watch. I'll see you over there.
Early on in my career as a heart surgeon, I learned there was a link between oral health and heart health. People that have periodontal disease, those people are at higher risk of having